Okay, hi everybody. I think we should start promptly. Welcome everyone. My name's Shivani Misra, and I'm a diabetes researcher and physician based at Imperial College in London. But I'm also a member of the EASD Academy board. And for those of you that don't know, the EASD Academy is a branch of the EASD that is specifically aimed at producing content for trainees, young researchers, young scientists, early career researchers. So we're really trying to direct activities in the EASD towards this group. And as part of that activity, we have monthly webinars, which are always at this time on the first Thursday of the month. And it's a great pleasure to be hosting today's webinar, which, since you've joined, you know, is about the ADA EASD Type 2 Diabetes Consensus Report. Now, I'm joined by a co-author of that report, Professor Chantal Mathieu, who is also president of the EASD as of this year, and has many other claims to fame. But my favorite one is that she's my mentor. So I'm very glad that she's here. And she's going to be talking to us about the EASD ADA consensus report, and has a short presentation. And then, of course, the best part of these webinars are the Q&A, which we'll be hosting afterwards. So without further delay, I'm going to hand over to Professor Mathieu. Thank you so much for giving up your time. I know you've rushed from clinic. Over to you.
Thank you, Shivani, and hello, Academy. So I'm extremely happy to be present in this webinar. And indeed, I can tell you that the board of EASD, I'm part of that for several years now, has been extremely happy that the Professor Patrick Schrouwen took it on himself to bring together a group of early career clinicians, early career scientists to really launch this initiative. I should say relaunch, because it already existed before, but you really put it on the map again and brought it into the 21st century. So congratulations to the board of the Academy, and well done. So when Shivani, you know, she is a cheeky woman. When she asked me to do this webinar, she said, actually, we want you to discuss what happened behind the scenes of the ADA ESD consensus on treatment of hyperglycemia in people living with type 2 diabetes. I said, oh, I cannot do that, because a consensus writing effort is like Las Vegas. What happens in Vegas stays in Vegas. But she said, yes, but, you need to teach us, because we are the consensus writers of the future. And so I agreed. And what we agreed together with Shivani was to actually discuss very briefly some of the highlights of the 2022 consensus, and then open it up to questions to you. And if you indeed want to know, what is the procedure, how does this happen, I'm happy to share with you without really revealing the big fights and the big emotions and everything that sometimes happens, because this is indeed the case when you are discussing evidence and looking at it with different angles. So let me start by sharing my screen, and voila, I hope everybody can see it now. And I will just activate my little pointer, voila, voila. So oh yes, first of all, I should start by my disclaimer. I do advise most companies who make tools and agents that help us treat people living with type 1 diabetes, type 2 diabetes, and other forms of diabetes, and my university gets the honoraria for that. So first of all, the process. At EASD, we welcome proposals for consensus papers. You should go to the EASD website, and there is the procedure on how you should announce a topic. And then the Committee on Clinical Affairs, chaired by Richard Holt now, looks at this proposal. and then approves this proposal or refutes this proposal, and then appoints people, EASD members, and that's a reason to become a member of EASD, to be part of the consensus writing committee. And then when the consensus is ready, they will review it and then endorse it and put the label of EASD on this. There are some consensus statements that are recurrent, as I would say, where we work together with other associations, and typically this is with our sister association in the US, the ADA. And so one of these consensus statements is on the treatment of hyperglycemia in people living with type 2 diabetes. And so every 3 to 5 years, on the amount of new evidence that is coming, we bring together experts from ADA and from EASD. And so it is the CCA who appoints the experts from the EASD side, and it is the ADA. They also have a committee who appoints people from their side. We at EASD decided in 2018 that we would have a cycle of 5 years with the same people. And that is why you see the same faces as those that were there in 2018, the update in 19, and now the new consensus in 22, namely the chair, Melanie Davis, Peter Rossing, who is an endocrinologist interested in nephropathy from Stino in Denmark, then Geltrude Mingrone, who is an endocrinologist from Rome, but also in UK, interested mainly in obesity. Svetlana Tankova, she's a new face who joined in 2021 to prepare the 22. She's from Bulgaria. She's a clinical endocrinologist. Then Professor Apostolos Tsapas from Greece, mainly also endocrinologist, but also a specialist in systematic reviews and data. And then myself, who have been there also from 2018, mainly interested in organization of care, translation, implementation of type 2 diabetes care. And so what you can see is that we make couples where we are coupled up with people from across the ocean, and we divide the approach, the review of literature, and then the writing of the consensus by topics. The rationale, for instance, was done Billy Collins and Peter Rossing. Then the whole review of the therapeutic options, so all the review of all the medications that are available, diet, exercise, etc., surgery by Geltrude, and then teaming up with Vanita Aroda and as said, Svetlana. Then personalized approach, the whole emerging evidence on direct organ protecting effects of new agents, the GLP-1 receptor agonists, SGLT2 inhibitors, etc., was Apostolos with Jennifer Green from Duke University. And then the fun group, as we call it, was me, Nisa Marutur, who is the primary care doctor in the US. But primary care in the US is very different from what we call primary care. They are internists, but they work in general medicine. And so Nisa was there also very interested in implementation. And then Silvia Rosas, who is actually a nephrologist. And so we came together and had, in my eyes, the fun bit, namely strategies for implementation. Now that we reviewed the literature, we made the consensus, how do we implement it? And as you can see, Bob Gabay and, where is Stefano? He's behind my screen there, Stefano. Also the two, he was the president, he was the managing director of ADA, and EASD also joined. So very intense process. The group of and then the co-chair was John Buse from University of North Carolina. The way we proceed was the group of Melanie Davis extracted all the literature since the previous consensus 2019, and then the groups were assigned a couple of hundreds of manuscripts to decide on where the big evidence, where the new evidence was emerging. And then every 2 weeks we had virtual meetings. And then we had 2 weekends where we worked, because this was end of 21 when we started, and COVID was still in the air. We decided that we would have 1 virtual weekend and then 1 face-to-face weekend. So very, very intense, I can tell you, with a lot of discussions. But again, being part of such a consensus writing group, you learn so much. You learn so much because it's all the same evidence. And still, you look at this evidence from different angles, from different perspectives. You know, a data specialist like Apostolos bringing in very important arguments, the clinicians bringing very important arguments. Very nice to be part of such an experience. Figure 1, we just took it again from the 2018 consensus because we thought it was so good, namely putting the person living with type 2 diabetes at the center of everything, making him or her a part of the whole team, you know, tackling the hyperglycemia in type 2 diabetes. First of all, assessing key person characteristics. Does this person have a myocardial infarction? Is he or she a frail person, etc., etc.? Then consider specific factors that impact the choice of treatment, namely, do I have access to GLP-1 receptor agonists? Are SGLT2 inhibitors reimbursed in my countries, etc., etc.? Then come to a management plan through shared decision-making, discuss it with the person sitting in front of you, agree on the management plan, implement the management plan, you know, not just write it down, but come to an agreement, also prioritize specific treatment decisions, and then get going. Provide ongoing support and monitoring not only of glycemia, but also of weight. Although the title of this consensus is treatment of hyperglycemia, we acknowledged also that this needs to be part of a whole multifactorial approach, and specifically weight is important for the treatment of the whole problem of type 2 diabetes, but specifically also has a role in glycemic treatment. And then very frequently review and agree on changing the management plan. And so this circle goes on and on and on. We couldn't make this figure better, and so we decided to keep it. The big table, we discussed a lot whether we wanted it. And then we said, yes, we want it, because it's the one that people always use and refer to. And so we made a slightly adapted one. We wanted to keep the blue bullet on the right-hand corner, namely avoid clinical inertia, modify treatment regularly, at least every 3 to 6 months. We wanted to keep the emphasis on diet and exercise. And again, I'm not a native English speaker, and I don't have a pejorative feeling with diet and exercise, but my UK and American colleagues, they went, ooh, we cannot have diet and exercise. We need to have healthy lifestyle behaviors. And so by that, we mean moving, healthy foods, etc., etc. DSMES, again, a very specific term, the self-management, education, and support. DSMES, very important to the Americans, again, because it means something very specific, structured education, as we would call it in my country. And then attention for social determinants of health, very important, again, when you decide on the treatment of hyperglycemia. For the healthy lifestyle behaviors, we introduced a new figure where we introduced this figure because there was a lot of new evidence between 2019 and 22 on, for instance, the importance of sleep, the importance of the contribution of very little sleep or a lot of sleep on insulin resistance, the influence of night work on insulin resistance. And so we really wanted to discuss that in our consensus, and so we brought that in. The importance, evidence growing on the importance of sitting, uninterrupted sitting, standing and sitting on, again, insulin resistance. The importance on strengthening of muscles, not only walking, but also, the muscle reinforcement behavior, etc., etc. And so I really encourage you to look at this figure and everything that goes with this figure, because that's where actually a lot of the new evidence came in the last 3 years. And then in this big figure, we now made 2 headings. And you see there's no priority on the headings. We said in everybody, we should have as a goal cardiorenal risk reduction, especially if they're high-risk patients with type 2 diabetes. And you hear me almost swallow my tongue, because we read and reread and rediscussed the fact that we didn't want to have one word of patient in the whole consensus. We wanted people living with type 2 diabetes, because again, that was an important statement. Again, in my country, not so much sensitivity, but in the US, in the UK, a lot of sensitivities. And so the whole manuscript was combed with a comb to, take out all patients. We left one patient in one of the big figures, namely here, high-risk patients with type 2 diabetes. But we said, okay, that should be a goal. But in everybody, also the goal should be to achieve and maintain glycemic goals, but also weight management goals. And so this is new again in this consensus of 2022. When it comes to glycemic and weight management goals, we said, make goals for every individual person. And also consider avoidance of hypoglycemia a priority in high-risk individuals, older people, frail people, people driving lorries, etc., etc. And then again, in the text, very important, we said, be proactive. Do use combination treatment from the beginning. Yes, metformin is a valuable glucose-lowering agent and a cheap one, but consider combination therapy from the beginning. And then we took a new approach and we just listed the glucose-lowering agents for their potency in glucose lowering. But as you can see, as important, glucose-lowering goals and weight management goals, we put them at the same height. And so we said in everybody, when you choose a glucose-lowering approach, take also weight into account. And so do not hesitate to consider metabolic surgery when indicated, medications for weight loss when indicated, intensify education when indicated. And when you choose a glucose-lowering agent, take into account the effect these glucose-lowering agents have on weight. And so here you can see, for instance, that sulfonylurea and insulin are even not mentioned anymore because they are weight increasing. And so we said when hemoglobin A1C is above target, reconsider education and go back to square one. What you see is that in this figure, these two are independent and both should happen in every person. You need to put goals for glycemia, need to consider weight goals, but also need to consider this part, namely in those with already an event, cardiovascular, or with a high risk, and we describe what we consider high risk because that's what we found in literature. When you have this individual, choose or an SGLT2 inhibitor with proven cardiovascular benefit or a GLP-1 receptor agonist with proven cardiovascular benefit. If hemoglobin A1C is above target, combine. If still above target, then consider additional glycemic lowering agents. heart failure is there, then it's an SGLT2 inhibitor with proven heart prevention of hospitalization for heart failure that should be there. If CKD is there, and that was actually a sentence that was changed just before the publication because the KDIGO guidelines were coming up and we would align them. So this was really last minute work, but we said, okay, we define CKD like in the publications, but there was a lot of discussion, what will we do? But then we aligned with the KDIGO guidelines, namely EGFR below 60 or albuminuria above 30 milligram per gram creatinine, then have an SGLT2 inhibitor on board. But when contraindicated or when not enough glucose lowering, then choose a GLP-1 receptor agonist with proven cardiovascular benefit in the population of CKD. And so all of this should be next to the glucose lowering. The rest, dear friends, I will go quite quickly, just putting what was the new evidence that really made us change this figure the way we did. As said, cardiovascular, here it was really the GLP-1s and the SGLT2 inhibitors that had more evidence between 2019 and 22, with real evidence coming out and put together in specific meta-analyses that we also took. And then our consensus recommendation in those with pre-existing cardiovascular disease, we said should, and that was not a lot of discussion. Where the discussion came was on those with without cardiovascular disease, but with an increased risk of cardiovascular disease. And I can tell you about this we discussed 4 hours. 4 hours. I mean, there were, in the end, there was one expert who said it should also in this population, but then we didn't vote formally. In the end, we convinced the expert to taper it down just a little bit because the evidence was just less broad. There were less people studied in this population, and therefore we made it a could. Background of metformin or hemoglobin A1C, there we were very rapidly all aligned. We said this should happen. Presence of GLP-1 or SGLT2 independent of metformin or independent of level of hemoglobin A1C in these individuals. Heart failure, again, no discussion, was obvious. SGLT2 inhibitor should be there. Evidence was overwhelming. And also the CKD. EMPA kidney was not out yet. We had credence, we had DAPA CKD, but again, the evidence also from the other secondary endpoints in the cardiovascular outcome trials were such that we were quite strong in our statements about the CKD people, and SGLT2 inhibitor presence should, again, not a lot of discussion there. And so this is what the figure looked like. It's two independent attacks, the direct organ protection, and then the goals. I showed you now the figures, but this is probably the most important, namely bringing it all together now. And so also indicating that the components of care should be, yes, weight management, glycemic management, direct organ protection, but also having everything in the context of cardiovascular risk factor management. And so a multifactorial approach, taking into account also the principles of care with psychosocial factors, social determinants of health, language matters. He's not a fat diabetic. He is a person living with obesity and type 2 diabetes. All of these things extremely important. And then, as said, bringing together everything. We wrote a lot about implementation, and I didn't bring the figures today, because of time, but we made very clinically relevant posters, I can almost say, on how to apply it. Also, the place of technology, for instance, in the treatment of people living with type 2 diabetes. A lot of evidence saying that use of sensors, for instance, CGM, in people with type 2 diabetes is as valuable in those injecting insulin as in those living with type 1 diabetes. Evidence in those not using insulin, less clear. Also evidence of use of pumps, for instance, much less clear in people living with type 2 diabetes. But so this is the slide that we snuggled in as the power group working on implementation. I didn't show all of our slides. You can download them for free from the websites of Diabetes Care and Diabetologia. It's the implementation slides. But this is the most important thing. Make it work. The evidence is there. The consensus is there. But we need to implement it in those sitting in front of us and needing our help in the treatment of their hyperglycemia. And again, in the next few weeks and months, there will be new modules also coming on our e-learning platform of EASD on this consensus with interviews of the experts. And so you can just go there, EASD-elearning.org, register for free, and you can access everything. So voila, Shivani, a very rapid overview of the big highlights, and I'm happy to answer questions on the what and how, but also the content.
Chantal, thank you so much. I don't think I've ever sat through a talk, it's probably my fault, where someone that authored the guidelines has taken us through them step by step, and just to understand why the decisions were made, and the language has been super helpful. So thank you so much. Now it's over to everyone who's online, because this is your opportunity, especially if you're in training, an early career researcher, a registrar, junior doctor. This is your opportunity to have an open conversation with Professor Mathieu and ask anything that you want about these guidelines without any judgment. There's no such thing as a dumb question when it comes to guidelines, and you've just heard things were very hotly debated. So please either put your hand up if you have a question or put it in the chat. Now, some of our attendees did submit questions ahead of the webinar, so I'm going to go to those first. Well, it looks like people are feeling a little bit shy. So there's one person put this question in, and I think it's a great question. Why does management of type 2 diabetes fail? And I guess maybe they're thinking about the fact that, you know, what we've learned from UK PDS and other studies is that type 2 diabetes is progressive. And no matter what you do, there's this inexorable progression. So just to sort of supplement that question, how much of it is healthcare professional factors, patient, individual factors, or just the disease?
Yeah, I always say that it's not the management or the treatment of type 2 diabetes that fails, it's the beta cell that fails. Until now, we have to be extremely honest. Not even our GLP-1 receptor agonists have shown that we can really prevent beta cell failure in the long run. The only little study we have is the Verify study. And again, we refer to it also in the 2022 consensus. We only have the little Verify study where vildagliptin, a DPP-4 inhibitor, was given together from the beginning with metformin to people with newly diagnosed type 2, very low hemoglobin A1Cs, below 7. And there it was shown that this early aggressive treatment actually delayed the need for, in those days, basal insulin initiation versus the sequential metformin and then vildagliptin treatment. So I think until now, we do not have any treatment that has shown to be able to protect beta cells from failing long-term, not even bariatric surgery. Even in bariatric surgery, we see that people after 5, 10, 15 years sometimes have, again, a recurrence of their hyperglycemia. And when you look at the beta cell behavior, it's the beta cell that failed. Now, why do we fail? I think we fail because it's such a multifactorial problem. It's a problem of what you eat as a person with type 2, how you're able to move. I am glued to this chair now for the next 3 hours. I should be moving. So it's not an easy disease. And it's a disease where genes play a role, where what I eat, what I do play a role. And again, where in the background, my beta cell is failing. So, yeah.
Thank you,
I
Chantal.
ramble, but it's because it's multifactorial, Siobhan.
Well, it is, isn't it? It's a great question actually to start off with. So we have a few fat hands up, and someone's also posted a question in the chat. So first of all, over to Ben.
Hi, Chantal. Thanks for that lovely overview of the guidelines. I'm going to preface this with I'm a basic researcher and not a clinician. So
I will not hold it against you.
Yeah, thank you very much. I'm interested in what is the most controversial topic in diabetes or hyperglycemia control at the moment, would you say? Which bit did you most argue about as to how we could manage it, or whether it should even be included right now?
As I said, the biggest discussion, Ben, was really on should or could for people with multiple risk factors for cardiovascular disease. Because if you're very honest, if you say should, it's 80% of people with type 2 diabetes, meaning that we do a lousy job in 80% of people with type 2 diabetes, because most of them in most of our countries will not be able to get access to GLP-1 receptor agonists or SGLT2 inhibitors. And so we thought we had to be honest and say that the evidence was just less broad, and therefore we said could. So that was actually the most heated debate. There were other debates that were heated, like about analogs, insulin analogs. So I was responsible for writing the piece about insulin, and yeah, you have to be extremely honest. That is that the arguments to use insulin analogs in people with type 2 diabetes, the only evidence we have, good evidence we have, is that basal insulin analogs give you less nocturnal hypoglycemia than human NPH insulin. That's it. Mealtime insulin analogs. So there's not really evidence to say they are better. So we didn't go there. So it's the only thing we put in, namely that you have less nocturnal hypoglycemia with insulin analogs. Other discussions on whether we wanted a piece on the importance of organizing your healthcare system and pushing your healthcare system to a more chronic disease management healthcare system. And you can say, whoa, what does that have to do with hyperglycemia? It has everything to do with implementation. If you have a healthcare system like in many countries where there's no chronic disease management, then it's the person with type 2 diabetes who needs to initiate the contact with the medical team. And if he or she doesn't feel the need to do that, and there's no recall system, or it stands square on the concept of chronic disease management. And that's why Nita Maruter actually was very, very keen on writing a piece on also organizing the healthcare system.
Thank you. Thanks, Ben. So we'll just take the next raised hand, which is Jean-Claude. And could I ask people to just introduce and say who they are, if that's okay. Jean-Claude?
Thank you, Shivani. Interesting you started with me about introductions. Yes, so merci beaucoup, Chantal. So thank you for that very brilliant and giving us insight into what's happening behind closed doors. So I'm Jean-Claude Kate. So I'm doing doing a postdoc research associate, working on global health diabetes research, really focused on diabetes in Africa. So my question is, so when I look at what you've presented and listen to some of the talks, how do you balance up looking at the newer anti-glycemic agents such as the GLPs and the SGLT2 inhibitors that really show these renal protective effects, but in terms of their glycemic lowering effects, there seems to be less than the traditional drugs. So how do you really balance this up when you're going for cardiorenal protection, but in terms of glucose lowering effects, it seems that these drugs have less effects probably than the traditional drugs. And my second question is...
Wait, I have an attention span deficit. Let me first answer the first question. Okay. So, very good question, Jean-Claude, because imagine that you have a person with an EGFR below 60. The glucose lowering capacity of an SGLT2 inhibitor is very, very little. So we said you should have an SGLT2 inhibitor on board for its direct organ protecting effect, but not for its glucose lowering effect. For the glucose lowering effect, pick one of the others. I also wrote a little bit about the people with renal disease. People with renal impairment are the most difficult people to control their glycemia in type 2 diabetes because you don't have any options. Many are contraindicated. Think about metformin. So in many of these people, you will end up with insulin. So it's an end story, Jean-Claude, where you will have an SGLT2 inhibitor or a GLP-1 receptor agonist on board for their direct organ protecting effect, and have something else, if needed, added for glucose lowering.
Yep. And the second one is just really, thank you, rapid one. As a member of the consensus team, do you, when I say you, I mean the whole team as a whole, ADA, EASD, do you have any feedback mechanism as to how these consensus guidelines are implemented in different countries, probably maybe North America and in Europe, at least?
Cher ami, that's one of our biggest frustrations after 2018, 2019, namely the implementation of guidelines, implementation of consensus. And actually now Rodika Busoy is the president of ADA, and just now we are discussing whether we could do a project to measure impact of these consensus. There was just a report by FPA, so the European Federation of Pharmaceutical Companies in Europe, who had, I think, PricewaterhouseCoopers do an interview in different countries on the hurdles against implementation. I mean, hurdles are multiple. There are economical. In my country, a GLP-1 receptor agonist is not reimbursed if you have a BMI below 30. And if you have an hemoglobin A1C below 7.5. So, I mean, there are economic hurdles. There are clinical inertia hurdles. And the fact that most of our people with type 2 diabetes are in primary care, who also have other diseases to treat. And the filtration, it's like water filtering through the ground. It takes time. it takes, webinars over and over again, repeating it. Because, I am very humble when I talk to primary care physicians. They need to know the antibiotics needed to treat a pneumonia in a child. So it's not easy. And we need to give them tools. In Belgium, we made a little app called the T2D helper app, where people can look offline to, a person with CKD, nausea on metformin, what should I take?
Thank you, Jean-Claude. Okay, I'm going to actually pivot to the chat because there are a few questions in chat, and then I will come back to you, Jan. So, question from Sophie Jones, Chantal, it says, do these guidelines specify particular quantified targets for aerobic resistance exercise, aerobic or resistance exercise, or specific calorie intakes to promote weight loss?
Yeah, if you look at the text, you will find some practical guidance there on the number of minutes of exercise, the calorie reduction you want to introduce. Yes, you will find it. Yeah.
Brilliant. And then another.
I don't know them by heart, honestly.
Thank you. Okay, another quick one from from Kirsten Brismar. She says, thank you for the nice presentation. The increase in treatment with SGLT2 inhibitors have caused many new cases of ketoacidosis in the emergency wards in Stockholm. What is the consensus about how best to avoid this?
Yeah, that's a very interesting remark, Kirsten, and it's actually not what the literature shows. So I would urge you to write this down and to report this if this is truly the case in Stockholm. So what we saw in the evidence is a risk of DKA that is real in some people with type 2 diabetes, mainly those with long-standing T1D and on insulin, but also in people on oral medication. So it does exist, but you will not find a big explanation on it in the consensus, because we thought it was really only a marginally increased risk. In type 1, however, it is a real risk. It is between 2 and 4% of people using SGLT2s as adjunct therapies in type 1 diabetes. But so write it down, this observation. And again, dear friends, publish.
Thank you. And then one more from the chat before I go back to Jan. So, Julia Rathnes, I hope I pronounced that correctly, has asked about the addition of finerenone to the guidelines. And I guess I'm going to just tag on my question, which is there's new agents coming out all the time, for example, tirzepatide. So what is the sort of cycle for updating the consensus? And I think finerenone came out afterwards, didn't it? After the
no. But we, the title of this consensus is treatment of hyperglycemia. So in the beginning, you have the disclaimer that we don't talk about statins, that we don't talk about blood pressure control, we don't talk about direct organ protective agents like the mineralocorticoid receptor agonist finerenone. So no, it wouldn't have made it into the consensus. We refer to, for instance, the KDIGO guidelines. So it wouldn't have made it there. What is the cycle? So we had a cycle of 5 years. But honestly, in type 2 diabetes, things evolved so rapidly that in 19, we had a very short update of the 2018 because there were, all these trials coming out. Now we left 3 years, but probably it will again be in the next 3 to 4 years. Because I don't expect the dramatic flurry of outcome trials that we had in the last years.
Yeah, okay, that makes sense. Thank you. Okay, so thanks for waiting patiently, Jan.
Okay, so I can talk now. Thank you very much for the very clear presentation. My question now is a bit broader. Given the fact that major excess in mortality among patients with type 2 diabetes these days is cancer and not cardiovascular diseases anymore, don't you think that we should start talking about cancer safety of anti-diabetic drugs more intensively instead of just cardiovascular safety profile? Did you touch this topic when you were discussing within the consensus report group?
Yeah, I was very happy with the beginning of your question, namely, as we are treating people with type 2 diabetes better and better for their cardiovascular risk, we are preventing acute cardiovascular mortality. And thus, we see cancer emerging. And because many people also with type 2 diabetes live with obesity, they will have an increased cancer risk. And so, again, it doesn't make it into this consensus because this consensus is about hyperglycemia. But for sure, if you want to translate, and again, I would encourage all of you, if you want to translate that to your national guidelines about treatment of type 2 diabetes, then I would urge you not only to talk about hyperglycemia, also to talk about blood pressure control, about renal, and about screening for cancer, because that now needs to come to the forefront, namely that we need to urge our primary care physicians to apply at least the rules for screening populations for colon cancer, do the faeces occult test, breast cancer screening, post-menstrual blood loss for endometrial cancer, etc., etc. So screening for the cancers, apply the population screens at least as well for people with type 2 diabetes as for others. Your second half of the question that we did look at, I mean, there is the evidence on prevalence of cancer with all of these agents. And I think there is some statement in the part that was written by Vanita Aroda and Geltrude and Svetlana on all of the different agents, that there is now enough evidence to put all the story of the pancreatic cancer and GLP-1 receptor agonists to rest. The new study, I think it's from Italy, on thyroid cancer and GLP-1 receptor agonist, I don't think it would have made it to this consensus because of the quality of the study. But it's for sure a thing we need to keep our eye on. But we reviewed, Vanita, Geltrude, and Svetlana reviewed all of the different agents, not only for their efficacy, but also for their side effects. And cancer doesn't really show.
Okay, thank you very much.
Brilliant.
Thanks.
Okay, Chantal, there's more questions coming in the chat, so I'm just going to pivot to the chat again. So Kirsten's asked, many of my patients with type 2 diabetes will achieve target HbA1c with their lifestyle modifications, or perhaps even lower. Should they be put on metformin or GLP-1 if they are obese, or SGLT2 if they have heart failure?
Yeah, so the easy one is heart failure, and another easy one would be CKD. So independent on hemoglobin A1c, yes, they should have an SGLT2 inhibitor. The other question about, I would say, prevention of type 2 diabetes, relapse of type 2 diabetes, we know from the old DPP that metformin helps together with healthy lifestyle behaviors to delay the progression to type 2 diabetes. So there is rationale to keep these people, even if their hemoglobin A1c is below 6.5%, on metformin. And there is now a lot of rationale from GLP-1 receptor agonists like dulaglutide or semaglutide, that indeed just treating people living with obesity delays progression to type 2 diabetes. So yes, there is rationale to do exactly what Kirsten is saying.
Thank you. Yeah, I mean, this is something that we really struggle with in the UK because of the NICE guidelines. Maybe, hopefully, they will change in the future. So another question, really an interesting one from Amna Malik. Do you think one can confidently start GLP-1 agonist on a patient with proliferative retinopathy requiring laser treatment, or should it be considered only in the presence of stable eye disease? I guess this relates to semaglutide specifically, right? With that.
Excellent question. I think, again, the whole story of the retinopathy and semaglutide has been put to bed, but the story about rapid glucose lowering and retinopathy is extremely relevant. So we know that if people have a proliferative retinopathy, a wild eye fundus, as I call it, then you want to avoid a very rapid lowering of your glycemia, be it with a very potent GLP-1 receptor agonist, be it with insulin, be it with any potent glucose lowering agent. So if you have a proliferative retinopathy, go in stages, bring them down a little bit for a couple of weeks, go down a little bit more for a couple of weeks. And so if you initiate a very active treatment and you bring them down immediately from 11 to 6, then you will see indeed a progression of retinopathy. I've seen a horrible progression of retinopathy in people with type 1, for instance, who were pregnant, where we want to, we have no choice then to bring them down aggressively. And that, combined with the growth factors of pregnancy, is a recipe for disaster.
So Chantal, where you said that the story around semaglutide had been put to bed, my take on that was that it was just related to rapid improvement in glycemia. Is that the case?
Correct. There's a very nice analysis of Tina Wilsbol, who is now actually our honorary secretary, so the woman responsible for the program of our annual meeting. So be nice to her. But so she did the analysis of the retinopathy in the what was it, the SUSTAIN trial. So she showed this very, very nicely.
Brilliant. And then one more in the chat before coming to Katerina. So Ritvika Malik asks, well, she says, thank you for an amazing talk. Is there any guidance regarding motivating younger people with type 2 diabetes to start treatment who are not concerned about long-term complications? So motivational aspects.
Yes, I mean, all of us who see people living with diabetes, finding the hole in the armor of the person, finding the entry gate to really get them to, you don't feel anything, and we ask you to swallow every morning a handful of pills and inject yourself several times a day or once a week, etc., etc. And so finding this little hole in the armor to get into a person. I mean, the one who finds the formula can come and tell me, because it's not easy, and it's all about personalized medicine. It's all about individualization of messages. And I like to explain to people what type 2 diabetes is, where you have a failure of the beta cell, you have a genetic predisposition, but that with behavior you can impact. You can move your muscles, you can make them work. They don't need insulin then to draw the glucose out of the blood. Making it plastic to people, using images, and really telling them they will feel better. They will be able to have normal pregnancies. they will be able to, see their children get married, etc., etc. So finding the little hole in the armor and the way you approach a person is different. I mean, sometimes I just talked to a guy with type 1 diabetes, hemoglobin A1C of 11, and he just bought a pub, a cafe, and he works day and night. He has no time. I said, I want you to be able to continue to work like a crazy fool, but you will only be able to do that if you have slightly better glucose control. Oh yeah, oh, that's important. Just.
It's all about the communication, isn't it? Always.
Yes, and
it's
very different person to person.
Yeah. Okay, Katerina, one super quick question, and then I just want to have some closing remarks.
Thank you, Chantal. My super quick question actually relates to patient awareness and patient involvement in the drawing of guidelines. Sorry, I might have missed something in the beginning, but for example, for obesity, there is a huge patient involvement. Patient associations are very, very, very present in the whole process at conferences. So what do you think about it?
Yeah, in the consensus, 0. Except once the consensus is written, so there's a timing. So we always have a draft by ADA where the first draft is presented, and then it's sent out to 80 or I don't know how many reviewers, and remarks by anybody are welcomed. We also send it out to people living with diabetes for their remarks. So then their voice is heard, but only at that stage their voice is heard. And thank you for opening this, because I can tell you that now EASD has taken the decision with Apostolos Tsapas and Richard Holt to make formal EASD guidelines. And so we just also last week at the board of EASD took the decision to have a patient advisory committee, because very often in consensus or a guideline writing, there is a patient voice, but it's very often a token patient who is sitting there, and he's very often not a patient, he's very often a doctor with diabetes or a nurse with diabetes, and then you go, so we want a pan-European patient advisory committee with different voices, younger people, older people, who can be called if it's about type 1, if it's about type 2, if it's about nephropathy. And so we want to try that formula, a patient advisory committee. And again, our guidelines will be happening. And again, if you're an EASD member, use your voice also to participate in this guideline.
Thank you. So thank you so much. We're actually coming up to the hour. So I want to please join me first of all in saying thank you to Chantal for absolutely fantastic presentation. But also thank you to everyone who participated with questions. I think it was a fantastic discussion.
Oh, can I say,
yeah.
The full slide set was downloadable via EASD.org. Simon, you may put in this in the chat whether this is still the case. The full one, the big.
I will add it to the website, so it will be available with the recording on the Academy site.
No, but I mean the one we presented at the EASD annual meeting.
Yeah, but they are not available at the moment, so we will add them again.
Okay. Brilliant. So, so yes, this will be available on the website. And if you've enjoyed this content, I'd really encourage you to join the EASD so that you can continue in the future to have access to this sort of content, and also help us, the board of the Academy, to shape the kind of educational content and support you need. So thank you, everyone. Chantal, did you want to say anything closing?
No, yay EASD Academy, and yay early career people, and you are the future.
Great. Have a good evening, everyone. Thank you.